thanks to the staff of the OAC. This is a 50,000 member organization, and it's basically run by 6 staff members. And when you see somebody in a red shirt with the OAC on it, please tell them thank you. There's a lot of work that's gone on in the background in order for them to put this conference together. And with that, I would like to bring up the program co-chair, Dr. Bob Kushner.
Thank you. Thank you, Lloyd. Thank you very much. I'd like to welcome all of you on behalf of the Program Planning Committee. And thank you so much for attending. To continue the theme of the individual journey, I want to talk about the roller coaster of life in women. Most of this conference will be talking about the individualization of treatment, and that is, how do you manage your weight? How do you take it off? How do you achieve improved health through diet, physical activity, pharmacotherapy in some, surgery in others? And that's extremely important. As a physician, when I meet someone on the first visit, although I'm thinking about treatment, what informs me about what treatment to use for that patient or recommend is their journey of how they got to where they are when they're sitting in front of me. And over the past 30 years, I have learned that everyone has their own journey of how the weight came on. Amber shared her journey with you and along with her sister and what they've done, and you have your own journeys as well. So what I'd like to do is to share with you what we've called the roller coaster of life, major life events that impact a woman's life, of the different times and events in a woman's life that may cause weight gain. And I think you'll see yourself a lot in the graphs and the weight curves that I'm going to be presenting to you. Men in the audience, I'm not leaving you out. You will be more empathetic when you talk to the women in your life, when they talk about their weight and you go, yes, I understand, I heard all about that. And that's all you have to say. And I think you'll be okay, rather than get over it, it's your problem. So, although I went to medical school and did residency and fellowship like all physicians, I could tell you that where the real learning begins and what makes one an excellent physician is by learning through their patients. And that is how I have become the physician I am, by listening to my patients' stories, and the treatments that have evolved and we've developed have really come out of the patients. So what I started to do quite some time ago is I've asked patients what one author calls an autobiographical approach, to show me in a graphic form what is it that has gone on in your life that has caused you to gain weight. And I have found these graphs, which I'll show you in a moment. They're instrumental in my entire presentation. Extremely self-reflective, intuitive. It allows self-learning, self-awareness, a deeper understanding on behalf of the patient and myself, because we go over these graphs together. So what I ask all of my patients to do, they don't all do it because of time restraints, or they don't download the form in advance, or they just are unable to do it. But the ones who are able to do it really find it to be extremely useful in a therapeutic relationship. So what I show them is this. It's part of a long form, but it's a weight life events graph. And there's a little instruction that goes on the top, and that is, in the graph below, I would like you to graph your weight starting at age 18, but for some people it's younger than that, and the associated life events that may have occurred during that time. That's all I say. So the graphs I'm going to show you, I can't prove their cause and effect. It's not a statistical study or prospective randomized trial. It's really probably even more important because it's the self-reflection that the individual has of how they viewed their weight as it relates to their event. Whether it's true or not, I don't know, but it's very meaningful to them, and it begins a part of the story. So let's begin with childhood and adolescence. That's regarding the life events. And this is a graphic form of one of my patients. Started high school with a little weight gain, felt good about herself. In the 10th grade, lost a little weight, broke up with her boyfriend, started gaining some weight, lost a little weight from graduation. I know Amber and her sister also lost weight at those graduation times. And then started college, you know, the freshman 10, the freshman 20, and so on. So this is a very vulnerable type in a woman's and man's life as well. In child and adolescence, the types of things that cause weight gain that we really need to be on the lookout for as parents for our children are limiting screen time, TV, computer, video games, smartphones. We know now because of budget cuts, there's less exercise in school, so that cuts the amount of physical activity, as well as the adoption of habits and skill building that is so critical during that time of self-care and becoming physically active and knowing what it feels like to be physically active. A lot of that is taken away from our children because of the reduction in wellness time or recreational activity. Liquid calories, we call them sugar-sweetened beverages. You're all familiar with that as a major cause of increased caloric intake. More meals eaten away from home than used to be. Certainly when I was growing up, maybe you as well, going out really was a luxury in the family. It may have been a Friday night when you went out for dinner. Now, at least in my patients, 2, 3, 4, 5 times a week is often eaten out. And with that comes extra calories and increased portion sizes. Much more snacking may occur during this time. And also we know that parenting and role modeling is extremely, extremely important. It's very important to get away from rewarding our children with food, or you can have your dessert if you finish your peas, that type of thing. Or if you bring home a good grade, you know, we're gonna go out for dinner and celebrate with a sundae. These are all the things that can lead to weight gain during childhood and adolescence. This is a cover of U.S. News, and we all know about this, and the whole article was about these sugar-sweetened beverages that are affecting children. This is a Georgia billboard campaign that the OAC really responded to very quickly when they saw this, and responded. They thought it was an inappropriate use of social marketing in order to increase awareness of obesity, but thinking of it in terms of childhood or adolescence, what does that mean for that child to go back to the school, and how much shaming may occur, which can lead to a vicious cycle of eating and shaming, and what do? I can't control my body weight. Some people think it's my fault, and it's really not my fault, and so forth. We also know there's a significant pressure of beauty ideals during this time. So the conflict that goes on, and particularly in a woman's life at adolescence, about forced dieting in one end, and the other side, this voluptuous model on the cover, and which one do you want to be, and the whole idea of which body shape and size do I identify with. So there's got to be so much turmoil and confusion that is going on during this time in an individual who is vulnerable to putting weight on because of a genetic endowment or biology or physiology. It's no wonder it's a time that childhood obesity is increasing during then. Fortunately, we have some campaigns that are going on. This is one of many, and you're all familiar with this. I just wanted to mention that from a public health point of view, the First Lady has really taken on obesity, but to her credit, it's not an obesity campaign, right? It's a Let's Move campaign in order to eat healthy and be more physically active, and it's really targeting childhood obesity. So it's going to continue to be a struggle. There's some new data out from the CDC that childhood obesity is leveling off. It's probably true, but boy, you're leveling it off at a darn high level. The glass is still, half full, and it's leveling off. So we need a lot more work to go on there. And that kind of turmoil that's going on in an adolescent's mind leads to this kind of weight graph. Rapid weight gain and rapid cycling, up and down, up and down. It goes down to that one moment in her wedding. I don't have a pointer, but that one moment you see the wedding where she finally gets into the gown, and the only time she's able to wear the gown is that night, and then rapidly goes to the weight cycling. When I, as a physician, look at this, I'm already thinking, is this someone who has binge purge behavior? Is this someone who has manic depressive thoughts? Is this someone who has body image issues? And likely so. And as a clinician, I'm cued into this immediately when she shows me this graph. She's only able, ironically, to stop this rapid cycling when she starts using intuitive eating, which is, I'm going to listen to my body. And there's some merit to listening to your body. However, in someone who is vulnerable to gaining weight, sometimes the signals you get are missed signals and you think you're never full. And that's what intuitive eating caused in her, and that started a rapid weight gain. And I saw her on this slope, this trajectory when she was starting to gain weight. Well, obesity and being overweight in adolescence and young adulthood has unfortunately a pay-forward problem, and that is there's an increased risk of infertility and anovulation. So if you are overweight during those critical times of 17, 18, 19, and so forth, the risk of having menstrual cycle irregularities, which is on the left, and primary ovulatory infertility, which means it's difficult to conceive, both go up, and the relative risk of having that continue to go up the heavier you are, particularly at age 18. So it has a significant impact on your ability to have a family and have children and so forth. So this woman who's seeing me, who has a cycling weight gain, comes to see me because her obstetrician refers her to me because she has infertility. She wants to have a baby, and that's what she's seeing me. So this is the medical impact of this weight gain so early in a woman's life. Now, if you think things can't get worse, when a woman does get pregnant, that's of course another time of having increased weight gain. And you see in this graph a woman who has the college 15, lost weight with diet and exercise, gained weight during her marriage, and then has 2 successive pregnancies with significant weight gain at both, and she never quite comes down to where she is. So after 2 pregnancies, she has what's called post-pregnancy gestational retention of weight. She has, in other words, 30 pounds of baby weight that remained on her. So that's a very significant vulnerable time in a woman's life, and that's a biological cause. For that reason, we are now starting to intervene very aggressively in women who enter pregnancy either already overweight or have post-gestational weight retention from a previous pregnancy, so she doesn't gain even more weight after that. So there's a time that we really need to be looking at. Here's a woman who, well, she just didn't get it. I don't know. Literally, this was what she handed in. Baby 1, baby 2, baby 3, baby 4, baby 5, then she comes to see me. So there's just an example of just the power of pregnancy, of constantly putting weight on, particularly in a woman who, in this case, had pregnancies successfully one after another because of her stage of life. She wanted to have a large family, and she started probably a little later in life and then really started having. She was probably a healthy body weight when she started, and then when she ended, she's now anywhere probably 70 pounds heavier, and now she's flattened up there. At Northwestern, we started a program, very clever, called Healthy for You, Healthy for Two, because now when I started my practice, pregnancy was that time that you would never intervene. It was a woman's life to eat what she wanted. You didn't know what the effect was of weight loss during pregnancy. Well, we now know that pregnancy is a very particularly difficult time for the woman from obstetric complications, as well as with the baby. So we've started a program in which we actively recruit women who are overweight or gained weight with a previous pregnancy. So the consequences of excessive weight gain during pregnancy include, which I've already mentioned, postpartum weight retention. In other words, keeping on the weight after the pregnancy. The others are obstetric complications, in which it's a very high risk of what's called gestational diabetes, right? So that's when your blood, every woman here who's been pregnant, they check your blood sugar. So if the blood sugar runs high, that's called gestational diabetes. That's an increased risk of type 2 diabetes if you don't take the weight off. Hypertension during pregnancy, eclampsia, which can be very, very serious, or preeclampsia, where you start spilling protein, you put on a lot of extra fluid, and your blood pressure goes up. And a cesarean section is increased risk for that woman as well. Also, a terrible consequence of increased risk of stillbirth. Shoulder dystocia is the baby is so large they actually have to, they bring the shoulder out and ends up with a congenital abnormality or congenital problem during pregnancy. because of the large baby, and shorter breastfeeding has also been seen, interestingly. This is actually the most alarming part of a woman going through pregnancy who's overweight. This is that pay-forward concept I talked to you before. And it's called fetal imprinting. And what we now know, primarily from animal work, but also now from human work, which has followed that, is that as a woman is overweight during pregnancy, that overweight environment changes the expression of the genes of the offspring or the baby within you, such that as the baby comes out through the birth canal, if you were overweight during pregnancy, that baby, before he or she takes her first breath, has an increased risk of having diabetes, obesity, metabolic syndrome, and heart disease because of the womb environment of a woman who is overweight. Nothing intentional, but it's all of that unfortunate pay-forward consequence. So if you think about why is each generation heavier than the previous generation, in part it's social norms and large portion sizes and sugar-sweetened beverages and reduced physical activity, things I mentioned earlier, but also because women are heavier during pregnancy and they beget heavier children. And it's called fetal imprinting or epigenetics. So this is a study that came out in 2004, which on the left is the maternal body mass index, which is a height-weight relationship we use to determine how heavy an individual is. So an underweight BMI is less than 18.5. Healthy weight is 25 to 29.9, overweight 30 to 30.9, and severely overweight is a BMI of over 30. And what you're seeing is the percent of children of these different women who had different weights during pregnancy, what percent of these children were overweight themselves at ages 2, 3, and 4, very young ages. And if you just scan through the numbers, the heavier the mother was, the greater the risk of the child being overweight. So if you take 4-year-olds, if the mother during pregnancy was obese or severely obese, 1 in 5 children or 1 in 6 children already are overweight just because of the maternal history. So it's a very, very serious problem. And for that reason, as I mentioned earlier, we now target women very specifically who are overweight or have obesity going into pregnancy or the risk of having it, or women with gestational diabetes, and we put them into a program. We are carefully monitoring their diet and their physical activity and limiting the amount of weight that we would like them to gain during pregnancy, so that, in women with obesity who are going into pregnancy, that's at the bottom here, we try to limit the weight gain to 11 to 20 pounds. It doesn't sound like a lot, and it's not. But that we have found to reduce the risk of offspring obesity. So we're trying to intervene in that. Of course, we have the family, we have the girth of a nation, so we have the father who's overweight, the mother is overweight, the children are overweight. If there was a dog, there is a dog, the dog's overweight, everybody's overweight. So we're talking about midlife, and midlife is by far the most complex regarding the determinants of weight gain. And I'll show you a few figures here to demonstrate that, because life becomes more complicated. So here we see college, we see marriage. I don't have a pointer, so you have to kind of follow me with my words. College again, and then we have some other interesting things. Quit cigarette smoking. Yes, quitting cigarette smoking is associated with, on the average, of about a 5-pound weight gain, but there's outliers who may gain 20 pounds or 50 pounds when they quit smoking. Then you have a divorce, which is a psychosocial problem that occurs. You have a new job, which causes problem, and at the end of this graph, you see promotion to VP, which is probably now I have no time for myself whatsoever, and my weight totally explodes, and on top of that, literally on top of that, living alone. So here we're talking about all the biopsychosocial problems that emerge, all these life events like a perfect storm on top of someone who's vulnerable to gain weight anyway, and it just explodes. We know that socialization is associated with being overweight. This was a fascinating study that came out in New England Journal, one of the most premier journals. And prior to this, what this same author, Christakis, showed is that cigarette smoking is a socialization effect. And what that means is that cigarette smokers hang out with other cigarette smokers, right? So if you know a cigarette smoker and you're friends with them and hang out with them, there's an increased chance you're a smoker too. That's called the socialization effect. He went ahead and looked at the same thing with obesity. And what was fascinating is that if you take the individual who is overweight, that's called the ego in this study. If you look at the bottom, it says a person whose behavior is being analyzed. So the ego is someone who's overweight. And then what he wanted to look at is the life, everyone in the person's life of that individual, what is their weight and what's the risk of one being overweight over the other? And a mutual friend turned out the increased risk of obesity of the individual was almost 200-fold increased if a mutual friend was also overweight. That's how you read that. Same-sex friend, about a 80% risk of you also being overweight. Everything was positive on there except an opposite-sex friend. That one came on the other side of the line. Well, how does that occur? Well, think about your own life. What do you do if hanging out with a group of people that are overweight, you pretty much pick what restaurant you want to go to Saturday night. You're probably not talking about let's go rollerblading, right? It's like a restaurant and a movie, and you almost have like a rotating dinner thing. You basically do what you enjoy to do, and you feed each other in this. That's what this thing is all about. So that's also something just to take consideration of as we age. We tend to take on the habits of the people that we tend to be around. Death in a family, more job stress, full-time job and school, death in a family, relocation, a short stint in Weight Watchers, illness in the family. So theme here is that the life event of probably loss and grieving and the responsibilities that go with that were in this person's mind associated with their weight. That's how it affected them. Maybe they turned to eating for coping. That's really how they ended up dealing with that. One more, college, job, stress, husband illness, can't read that. Thank you. Death of a husband, stress in relationships. So these are all the things that occur. It's not as easy for me to make that connection of how do these dots go together, but what I do as a clinician, when I look at this with the individual, I go, tell me the story. What is that relationship? How is it that the death of your husband caused you to keep gaining weight? And they're able to tell me immediately. You know, I wasn't going out as much anymore. Our couple friends were not really taking me out. I was sitting home more, and I was kind of bored and lonely, and I really started eating more. I didn't feel very good. And it's a kind of a subtle type of relationship of what actually goes on there. This is from a study called Stress in America, 2010. And I use this when I teach in a medical school about what causes stress among Americans. And what's interesting about this graph is how important is this particular goal in your life, and how close have you been able to achieve that goal, and what's the gap? Okay? So at the very top it says, having a good relationship with my family. It was scored the highest among life goals among Americans, and the gap between achieving it was 19%. It sounds like a lot, but when it get down to the others, it was actually one of the smallest. So it's like most Americans really haven't been able to reach that goal entirely. The next one is having good relationship with my friends. There's a 15% gap. Doing well in your career and studies, 17% gap. And then you get to, which is fascinating to me, the self-care behaviors. So the others are external, relationships, career, right? Then you get to, how about me? Where do I come in? Getting good night's sleep, 38% gap in what I want to achieve and what I'm actually able to achieve. Managing stress, a 32% gap. Eating healthy, 27% gap. Lastly, being physically active or fit, a 27% gap. So it's no wonder to me, I think, that is Americans have a big gap in taking care of themselves, right? And then you layer in death of a spouse, loss of a job, right? All of a sudden I got 2 kids and I'm carpooling. I don't know how to take care of anything beyond taking care of my kids. It's no wonder that self-care behaviors, that gap probably even widens, And what's the manifestation of that gap? In people who are vulnerable, you put weight on. That's the visible manifestation of not eating healthy and being physically active, is you put weight on. So I think that's where a lot of that link is. Psychosocial stress is associated with a change in body weight. This is just one study I pulled from the literature. Among women enrolled in the midlife in the United States, called the MIDAS study, who were overweight, further weight gain was associated with, these are the things that came out as significant variables: job-related demands, perceived constraints in life, strain in relations with family, and difficulty paying bills. So this is basically where that association comes in someone who's vulnerable, who your go-to coping is eating. It's no wonder that weight is likely to occur during those times. So we talk a lot about in our program and in our medical school and so on, how are you going to cope with life events? Life happens, right? Things coming at you constantly. And it's not so much the stress that causes the weight gain. It's really the coping, it's the pushback that really is the most important thing. So we teach a lot about coping skills. Life is never going to be stress-free. A negative way to cope would be you disengage, you shut out your friends. You avoid the problem. Somehow it's going to work out. I just believe it's going to work out. I'll wait it out. Wishful thinking, right? Someone will come to my aid and take care of it. Social withdrawal. You don't call friends. You don't open up. And you criticize yourself. Either I'm not worthy, I brought it upon myself, one more thing that's happening to me. And what that directly leads to is depression, anxiety, and excessive eating. And what you want to do instead is what we call positive coping. Again, stress is always going to happen. What is positive coping? Well, it's just the opposite. It's engaging with others and with the problem. It's problem solving. How am I going to actually deal with this? It's positive reinterpretation. That's the whole idea of life gave me lemons, I'm going to make lemonade out of it. Social support. Call on your family and friends. Don't isolate yourself. And express your emotion. Don't keep it all within. And that's how you adapt, and that's what leads to resilience. So all of these life events are going to happen. This is where the money is really, is how am I going to learn to deal with this? Obesity is associated with depression. Many studies show it. I'm just showing you one study. The patient health questionnaire, called a PHQ, is what clinicians use as a self-scoring instrument. When you see a patient, the higher the score, the higher its association is with depression. So the probability with obesity is on this vertical axis, and the score on this questionnaire is going along the horizontal axis. And what you see is the prevalence, or the percentage, of those individuals who had obesity according to score. So once you get to a score of 15 or more, which is associated with moderate or almost severe depression, 60% of individuals already had obesity. Now, this doesn't prove cause and effect, of course. Sometimes being overweight makes you darn depressed, right? And actually it's bidirectional. Being depressed can also cause you to be more shut in, reduce your activities, and eat more. So it's actually bidirectional. So this is actually demonstrated, this bidirectionality of depression is shown here, is that someone gained weight during depression, got a handle on their weight, but then had a relapse because of a death in the family and was put on antipsychotics, which is sometimes used for depression, and actually caused weight gain. So as clinicians, we have to be very careful when we use medications, diabetes and all kinds of medications. But for depression, we have to be very careful as well, because we can actually cause weight gain by using the wrong medication. Same thing with schizophrenia, psychosis, bipolar illness, and so on. So we have to be on the lookout for that. Reduced sleep is probably one of the most interesting and provocative areas in medicine now, is that data is very strong now, at least from an epidemiologic point of view, that if you take questionnaires from large groups of communities, individuals, as the number of sleep goes down, so the duration of sleep goes down, body weight goes up. And we also know from a whole set of other studies that are done in the lab, the clinical lab, that if you take individuals in who are normal weight or overweight and start to shorten their sleep cycle, you artificially do it by changing the light and restricting sleep time, you can actually demonstrate changes in metabolism, changes in how the body handles blood glucose, changes in cravings of food in a very short period of time. So sleep is a vital sign. It's as important as your height, your weight, your blood pressure, and so on, as how many hours do you sleep. I don't think God would have us sleep 1/3 of the day, if you want to think about that, if it wasn't critically important. Roughly 1/3 of our day is spent in sleep. It has a very, very important critical function. When you rob yourself of that, you start changing your metabolism, and it's associated with increased weight. So again, we know when we look at sleep in America, it's another survey done, Americans are sleeping less now than they did 30 years ago or 40 years ago when prevalence of obesity was lower. So it's likely to be yet another factor or determinant that's linking obesity. And let me also end here on hormones, because midlife in a woman, you're talking about at some point entering menopause. And that is the most challenging time, or challenging story that I hear. And it goes something like this: someone took over my body. This is not me. I never used to look this way. I never had this belly before. I didn't have these 20 pounds. Nothing has changed. And I go, when did you go through menopause? Oh, well, right around the same time. So there's significant hormonal changes that occur, and primarily, not so much in body weight, although many women have that, it more significantly affects body shape. And what you see here is two graphs over multiple decades of women who are aging. On the left is the body mass index, right? That's a height-weight relationship. The higher the BMI, the more overweight you are. Right is the waist circumference in centimeters, so just the circumference of the waist. And what you see is over time in women, and it's also broken up by racial and ethnic group, there is a steady increase in body weight, but there is also an increase in waist circumference. And in this particular data, which is from NHANES, which is the national survey, black women had the highest increase in waist circumference, followed by white women, Hispanic, and total, and so on. So we know that is going on. And paying attention to your waist circumference is extremely important, because increased waist circumference is associated with increased risk of high blood pressure, diabetes, abnormal fats in the blood, breast cancer, and so forth, because of the fat that's inside the abdominal cavity, which is called visceral fat. So that's a CAT scan of the abdomen. It's not the fat so much that you could pinch an inch, which is shown on the left. That's not so much the culprit, the bad fat. It's the fat on the inside that you can't pinch, and you have to look at it through things like a CAT scan, and that's what's actually shown there. And I want to share one study with you by Jennifer Lovejoy, which is one of these few studies that took a group of women prior to menopause, looks like about 4 or 5 years or so before menopause, knowing that, of course, they're going to be going into menopause at some point. So these are women in their mid-40s, late 40s, and started measuring a variety of factors and things in them, like weight and height and percent body fat. So she uniquely captured the same group of women as they went through menopause and then after menopause. And she wanted to know what was the cause and what was actually going on in the body. So what you see here are 4 graphs. The top left is weight, it's in kilograms, and then percent body fat is in the upper right. Visceral fat, that's that fat on the inside, which is the bad fat, and then the subcutaneous fat, which is the pinch and inch. What the blue arrow is menopause. So every woman in the study, the blue arrow is when they went through menopause. So what you see here is body weight started climbing a little bit before menopause, which is where that blue arrow is. Body fat started climbing a little bit before menopause and stayed elevated. The visceral fat, the bottom left, really started climbing significantly again before they actually went through menopause. Menopause, by the way, is absence of a menstrual cycle, right, for 6 months or 12 months, depending on the definition. And then the subcutaneous fat went up too. So clear changes in body weight and body shape that occur actually before you, during perimenopause, when your period starts to become somewhat abnormal. Hormone changes, your estrogen levels, which is called estradiol, start to go down, right? At menopause, they're very low. And then these other two hormones called follicle-stimulating hormone, that one starts to go up. The bottom two is probably the most important thing of all the data I'm showing you. And that is menopause a problem of taking in more food or reducing your physical activity or neither? And what her study showed is that the real change occurred in a reduction in physical activity prior to the menopause and stayed low during menopause, whereas total caloric intake, which is the bottom right, actually started reducing during menopause. So to summarize what this data shows is that menopause is associated with a change in body shape primarily, but also a little bit in body weight. And it seems to be the reduction in physical activity that is the one thing that can really be worked on. Now, maybe it's so subtle that for those of you who went through menopause don't realize it, but at that age, you're often perhaps becoming a grandmother, or you're settling down because you're taking more vacation time, or you're less physically active than you were. So those daily activities may be coming down, and at least that's what she showed. So the decline in physical activity in midlife and a little bit later is probably the work-related activities going down, transportation is going down, you're probably taking more cars and so on, less walking, activity at home may be going down, sedentary activity may be going up. That arrow's up is wrong, that should be going up. In total, physical activity is probably going down. So in summary, understanding the role of life events in weight loss and weight gain, it's not necessarily the event per se that results in behavior change, but the ways in which this event is interpreted or reacted to. Thus, the same event could result in weight gain for one person or weight loss in another, or for the same person at a different time. So again, stress happens, life event happens. It's how you interpret it, particularly those that are vulnerable to weight gain. So in summary, there are multiple events in a woman's life that predispose her to gain weight. The reasons for weight gain at each time point differ. It's a combination of changing biology, hormonal status, and life events. It's important to implement preventive and treatment strategies to halt further weight gain in the development of ill health. So thank you very much. Thank you. So we do have some time for some questions. There's two microphones at both ends. I'm going to ask you to go to the microphone, otherwise no one will be able to hear you, including me. So if you can go to the microphone, and I think, again, we'll be able to do that for a little bit yet. Please.
Hi, yes. My name's Sarah. I actually have a condition called lipedema that is primarily in women, and a lot of it is triggered at those times in life that you described, either puberty or in giving birth, menopause. Have any more information about the role of, you were saying the waist and the lower body is where
right. You said you had lymphedema?
I have both, but lipedema is the one of the subcutaneous tissue, the abnormal accumulation of subcutaneous tissue.
I don't have any particular information regarding that condition in life events. It may be just the way that your body responds, but I don't know of a literature to actually inform me or you a little bit more about that.
Okay, thank you.
Yeah, yes, please.
Hi, Dr. Kushner. My question is about women's weight and pregnancy and effect on children and their weight. So I'm getting married in a couple weeks, and I've been talking about having a family, and both my fiance and I have struggled with weight, and I didn't know if you knew like what the data shows for people who have who've lost a lot of weight and gotten to a healthy weight and then had children, and like what the effect was on, I guess, in families. Was it still as high? Do you know what I'm getting at? I guess, right. Even though I have a history of morbid obesity or extreme obesity, right. What are the chances of my children, I guess,
Yeah, so
developing?
it's an excellent question, which separates out between what is the genetic endowment that you have that you may pass along in your genes versus the environment while you're pregnant, which is the data I showed you. I could tell you that we do have some studies of women who went through bariatric surgery, and you looked at the weight of their children before bariatric surgery and when they got pregnant after bariatric surgery and lost weight, and what happened to those children. And I don't think the studies are long enough, but we know that the birth weights are healthier, the complications of the women are better, and in the early birth weights, at least, of the children after bariatric surgery are healthier. Now, again, those studies are not long enough out, but it suggests certainly that you've taken care of the environment that the child is growing in as a healthy one, and that's going to have a huge impact. What it will never change, though, is the genetic endowment that you bring to that child. But basically, you're doing all you can do in a very positive way by having that child be as healthy as possible when he or she is born. And then the rest of it is role modeling and parenting and being on guard.
Thank you.
And good luck in your marriage.
Thank you.
Okay. Yes.
Hey, Doc. I just want to say thank you again for the great run this morning. That was awesome. I hope everybody else shows up to the run and the walk tomorrow morning, too. So, you were also mentioning with weight loss or prevention of weight gain during pregnancy. So, if you were to have a woman who was already obese, say in the morbidly obese range, would you want her to lose any weight during her pregnancy, or would you only want her to gain the 11 to 20 pounds?
The IOM guideline is for women with a BMI of over 30. So it doesn't really, it's not, I think, detailed enough for a woman with severe obesity. So we're really on uncharted territory. If we stick to what we know, we want to limit the amount of weight gain in that woman, perhaps to the level there. But it may be that a woman with severe obesity who gets pregnant shouldn't gain any weight, and the energy should come from her. But we don't have that data. So until that data is available, we stick to the IOM guideline, which is minimal weight gain up to 20 pounds. We need more information.
Sounds like a great study. Thanks.
Yeah. Well, the one thing we don't want to experiment with, clearly, is during pregnancy and so on. So maybe it'll turn out that a woman who goes into pregnancy who's 100 pounds overweight should lose weight during pregnancy. We just don't know. That has to be very carefully studied. Yep. Yes?
Hi. Carla Harrison. I had bariatric surgery in 2003. And my question is about exercise with women with the calcium issues that we have. And having been a couple 100 pounds heavier in the past, I wonder about running and things that are hard on the joints and how that affects the bones and the calcium loss that I've probably already experienced. And if there's anything that, other than just taking the calcium routinely, the proper type of calcium, is there anything else that we as women can do?
You're a little bit out of my expertise with that question.
Okay.
Really other than what you probably know, and that is maintaining enough calcium and vitamin D and stretching and all bone health. But really to give you more specific advice on that is really a little bit out of my expertise.
Okay.
I hope you'll be able to get that, though, over the weekend, by talking to others.
Okay, thank you.
Okay. Yep. Why don't you bring your microphone down a little bit towards you?
My question is similar to the question of the gentleman before me. My question was going to be, if a woman is obese, has had surgery, and then becomes pregnant, and is still eating healthy, getting all her nutrients in, but losing weight, not tremendous amounts weekly, but losing weight through the pregnancy, what would your counsel be?
If I saw a woman who, if they were getting all the nutrients they needed and were maintaining a healthy lifestyle during pregnancy, and either were maintaining their weight or losing a little bit, I'm not sure I would intervene. I'm not sure I actually would tell her to gain weight, as long as I was assured that her diet and physical activity and her nutritional supplementation was adequate. But again, we don't really have the data that I know of. But that's how I would be treating that woman.
Okay, thank you.
Yep.
Hello, I'm Julia Carlstead, and I'm an exercise physiologist and personal trainer. I'm very intrigued by the information you provided as far as postmenopausal women and the statistics with physical activity. My question, I guess, is do you know of any data or have an opinion about postmenopausal women in hormonal therapy as it relates to weight loss? I have a lot of clients that have started different hormonal treatments as far as testosterone and stuff like that, and I would like to know your opinion or if you know of any data out there with that.
Well, there is some data. I don't know a lot about taking testosterone or androgens, but there's certainly a lot of data on hormone replacement therapy in those women. And as you probably know, that has to be discussed pretty carefully with the doctor because of other risks that may go with hormone replacement therapy. But that can have an effect on your body composition and on your waist circumference. Probably subtle, but a little bit.
Thank you. And then I just wanted to add some advice for the lady who was talking about the calcium, and definitely recommend strength training for bone health. So.
Right. Yep.
My name is Lee Moore, and gastric sleeve surgery, and I am wondering my surgery, and this microphone's not working correctly. Will affect my grandchildren and my children. I have a 35-year-old daughter who just told me she is pregnant. Very excited.
You're going so in and out that I'm actually losing your. Do you want to walk over to the other mic?
Yeah.
I'm sorry, but I can't get the gist of the question. So we'll probably do these last two questions because you guys need to take a little bit of a break. So why don't we go ahead. Why don't you ask your question? She can go ahead. Okay.
All right. I have had obesity surgery. I've lost about 120 pounds. My daughter is 35. She struggles with 30 to 40 pounds of weight on and off. She's 35, as I said, and she's expecting a baby. She's very early in her pregnancy, and I was noticing on your chart some of the information that might be helpful to her. So what my question is, how much should we have her watch her weight loss or gain during her pregnancy to have her have a healthy baby? And has she inherited my genetic tendencies, because she's not morbidly obese and has never come close to that?
I don't know if there may be some data on lineage, which is, going back to the grandparent and so on, kind of a family tree thing. But the only data I'm familiar with is the mother herself and the risk of the offspring from the mother going into pregnancy being overweight. And the IOM recommendation, I didn't catch the weight of your daughter, but the IOM recommendation is even if a woman is overweight, there is also already a limitation in the weight gain that we are trying to impose versus the woman who is healthy weight. So you don't have to be morbidly obese to have that particular risk. So I would probably work off of whatever her weight is. That's the recommendation I would make. And I'm not really sure what the impact is of your weight on that.
Well, I'm not concerned about my weight on that. I'm concerned about...
Your weight on your grandchild.
Oh, okay. I understand.
Yeah, I understand that.
Oh, thank you.
All right, let me take last question, if we could, please. Yep.
I don't know whether this is a question or a comment. My name is Nick. I had gastric bypass surgery 5.5 years ago, and the part of your talk that most resonated with me was about the fetal imprinting. And thinking about the course of my life, I am the result of a woman who had gestational diabetes. I was born over 9 pounds, and then I went on to become progressively across my life a bigger than normal child, bigger than normal teenager, bigger than normal adult. Went on to have 2 children, and now I have 1 child that's overweight and 1 child that is obese. And so I guess my thought is, I wonder sometimes to myself, with the result of my surgery, and it's just sort of a natural byproduct that when you get people who've had surgery together, that you sort of, even in your own mind, compare and contrast. Is it do people's bodies work differently, or have studies shown whether or not people's bodies work differently if they've historically always been larger than normal versus someone who gained weight at a point in their life associated with something and then attempted to lose weight? Because I always wonder that, is whether or not people who have always been big, whether their bodies work differently when you try to lose that weight.
They do. And that highlights the complexity of being overweight. That is not simply, right, a problem of personal responsibility and I don't take care of myself. We know there are clear biological, genetic, and physiologic differences between someone who is vulnerable to gain weight versus someone who has been so-called naturally thin. And as someone who is overweight loses weight, your biology is very different because your body knows you lost weight. So that's a whole nother talk, but the short answer is absolutely there's differences. All right, Lloyd.
I'm sorry, I just want to make a brief comment on, I think to emphasize your point, not only is it weight gain during the pregnancy, it's the food environment that mother's taking in during that time and the fat percentage, the carbohydrate percentages, those types of things. All of those obviously continue to add to weight gain, but it's the environment that that child is surrounded in the womb that's probably making a great difference as well. And I would tell you, and again, I completely agree with Dr. Kushner, there's not enough data for us to be able to say, clearly this is how much weight somebody needs to gain. But I would tell you in my own weight loss surgery patients, they don't have to gain any weight during the pregnancy if the baby's growth is normal. And that's really what we're following. If the baby's growth is normal, they don't have to gain any weight, for me, in my practice, for them to be nutritionally sound during that period of time. That's the real key, I think.
Right. Thank you. Thank you all very much. Thank you. Hi. Huh?
Joe, Travis needs your help.
I know what you're doing.